Good afternoon, everyone. Welcome to today's DCRI Research Conference. It's a real pleasure today to introduce Dr. Arif Kamal. One of the topics he'll review is palliative care. And palliative care is something that not all of us hear much about, but I think it's a very nice example of a field that sort of epitomizes the value of personalized medicine. So palliative care is personalized medicine for individuals with serious and life-threatening illnesses, as well as for their families. And throughout all of our daily lives, we are able to use technology to make our lives easier. And perhaps surprisingly, this ability to have sort of ubiquitous technology and tools around us is actually potentially very relevant to palliative care and personalizing the complexity of needs for patients with serious illnesses and their families. And today we're going to hear from an expert in this field, an emerging leader who trained here at Duke in hematology oncology prior to joining faculty as an assistant professor. He wears a number of hats, including as director of the Palliative Care and Quality Research Program within the Center for Learning Healthcare, as well as director of quality and outcomes at the Duke Cancer Institute. So please join me in welcoming Dr. Kamal.
Thank you. Great. Well, thanks. Well, as Dr. Patel mentioned, right, so palliative care is this very quickly growing medical discipline that remains actually quite immature in sort of how it's evolving and how it's evolved so far. Yet clinically, as a specialty, the number of clinicians and the number of programs across the country has grown quite remarkably. So, for example, in the last decade alone, we now have palliative care programs within 85% of all hospitals with 300 beds or more across the United States. You compare that to about 10 years ago, that number was closer to 25%. The number of palliative care board-certified physicians in the country is probably around 7,000. And I just read something this morning that probably the number of board-certified or certified nurses is probably around 13,000. But if you think about the number of cardiologists, nephrologists, et cetera, in the country, the number of nurses, which is the number is actually about 1 million nurses in the country, it's a very small workforce compared to actually the number of patients we're thinking about treating. So what we're going to talk about here through about the next 45 minutes or so is how our group within the Center for Learning Healthcare has been tackling both, one, a quickly growing medical discipline, two, a medical population of patients and caregivers who are also very quickly growing, yet have very few tools to access to help sort of understand their own needs as well as communicate those needs with their clinical providers. And three, giving tools to clinicians, very busy clinicians who are faced with doing this daunting amount of work that is actually getting a lot bigger over time. So I mentioned 6,600 board-certified physicians. Right now, it's expected that the number of palliative care physicians in the country, if you take the normal rate of attrition, the normal rate of burnout, and the number of those coming into the field based on fellowship positions, we've modeled that probably somewhere around 15 years that we may actually have a negative number than what we have now, because there's no way that it can keep up. And I imagine in other fields like cardiology and others that you've been thinking about that. Palliative care is one of those spaces, though, unlike maybe other disciplines where CMS, NQF, payers, et cetera, ACOs are all saying we need it and we need a lot more of it. So I'm going to have you think about that as we go through this talk. Here are my disclosures. Sorry, real quick. And I want to first actually start out by acknowledging a great group of people who help us work on this together. And I know a lot of people put acknowledgement slides at the end. This is really the idea that none of this work is actually mine. This is the work of a large team that works very hard at making this happen. And so I want to acknowledge certainly those who work directly on Qdac, those who are within the Center for Learning Healthcare team, and the mentors that are part of all this work. So I want to sort of help drill down on what this talk is actually going to be about. So our focus within what I'm going to talk about today, and as one of the sort of three foci within the Center for Learning Healthcare, is research on quality. And so that's sort of our research focus. And within that, we think of tools that one might use. And in this case, I'm going to talk about technology and informatics, both hardware, software, and the back end. And then lastly, what we're going to apply it to is, in this case, palliative care. But what I want you to think about is, as I'm talking, you could think about research on quality using other tools and other methods that are not technology-based, for example. Using tools other than, so you could use paper-based examples for what we're going to talk about. And then there's clearly other use cases other than palliative care. So I'm an oncologist. who does palliative care. So you can think about applying this on oncology, but certainly you can think about applying this in cardiology, nephrology, endocrinology, and so on. So I want you to think about how this could be applied outside of our little window into the things that you do. So a lot of people have been attributed to this quote. It's actually probably first mentioned in The Emperor of All Maladies, which is a great book about sort of the evolution of cancer care in the United States. But actually, probably the first person to have said this was Bernie Fisher, who was a breast cancer surgeon who in the early 1970s, when NSABP, which is one of the big sort of collaborative groups in oncology, was starting to put together the first randomized controlled trial comparing the radical mastectomy, the Halsted mastectomy, versus the modified radical mastectomy, which would be a lot less invasive. And at the time, the idea was, well, listen, if you have breast cancer, you take out every single lymph node, piece of tissue that you see, and you just cut it out. And whatever morbidity, lymphedema, pain, neuropathy, thoracic syndrome, et cetera, that people are left with is an okay part of that process. When Bernie Fisher started putting this trial together, people thought he was crazy. They said, why would you do any less surgery? How would that make any sense? You're going to leave cancer behind and people will actually die sooner. Yada, yada, yada. NSABP B21 showed that there was no difference in survival, which has really been the hallmark of how we've now approached cancer care, where in fact actually more may not be better. And he said this quote, "In God we trust, all others must have data," and this was this idea that data and informatics was the way we were going to be able to tell what works for what's going to work best moving forward. So, several different groups have actually talked about what quality of care should be defined as. And what I'm going to point out is whether you're the Institute of Medicine at the top, you're the Centers for Medicare and Medicaid, you're the National Health Service from England, or you're Don Berwick, this whole idea is that every part of your definition requires that you are doing some amount of data collection. Note that nobody says here, well, you sort of just put your thumb up and you sort of go, I think it looks okay, and I'm going to go with that at the end of the day. Every single one of these say, for example, health outcomes, consistent with current professional knowledge. So that requires looking at two pieces of data at the same time. What are the outcomes? And then how is those outcomes mapping to actually how care is delivered? So is it consistent with guidelines, best practices, et cetera? And then the National Health Service actually said very clearly that it is the job of those in healthcare. So clinicians, scientists, every one of us actually, it is inherent to what we do that we have to be improving the healthcare delivery system. And Don talks a lot about reducing a lot of the unnecessary things that we do. So if the IOM puts forward that there's 6 domains of quality of healthcare, that clearly means that there are at least 6 large areas that we could be studying when we do research on quality. So certainly care can be safe, but it could be error-prone, it could be patient-centered or unresponsive, and et cetera. And that means that there are at least 12 different important research questions embedded just in a document from the IOM now almost 15 years ago. And you can start thinking from the National Quality Strategy, new guidelines that come out. An example that we know in palliative care we're dealing with now, a real-life example, is when the changes were made to the ACC-AHA update regarding who should receive statins. That was one of the first things that actually palliative care physicians read too. Because the idea is that you could have a 75-year-old man with diabetes, hypertension, who's a smoker, who has a 10-year acute vascular disease risk of 75%, which is what that calculator would say. But if I know they have metastatic pancreatic cancer and they have 6 months to live, okay, but then I give them a Braxane gem, for example, and now they have 14 months to live. Actually, the appropriateness of statins in that patient may actually change dependent on 1, their functional status, 2, their estimated prognosis that I may give as an oncologist, and 3, the new lines of therapy that are coming out. Because 2 years ago, we would have said metastatic pancreatic cancer is right at 5.4 months. Now, 2 years later, we're saying it's probably closer to 14 months with some of the newer things we're giving. So these are a rapidly evolving area that we think about where appropriate care should go. So as you can see, that's how we sort of think about the questions that we're approaching. Additionally, I mentioned the importance on informatics and what we do as a group is we think about how can data actually be used in one of 3 ways. And so we call this our data triple aim, which means that one set of data can actually be repurposed for multiple reasons. And certainly you guys have probably heard of the Learning Health System, which is really where sort of the Center for Learning Healthcare came forward. But most people don't imagine when you're talking about a learning health system that you're talking about quality of care. They message it as evidence development, understanding outcomes, et cetera. But what people don't commonly think about is how data can very easily then give you a sense of the quality of care you're delivering. So let me give you an example. We know that NQF, NQF is the National Quality Forum. 0209 is a measure that says all patients who are receiving palliative care should have a comfortable pain number within 48 hours. That is a payer-based measure that's being used by CMS for all hospices. All hospices, as of July 1st, have to report 0209 every 6 months to CMS to be certified, which means they're now doing this quite regularly. And in the outpatient palliative care setting, we're thinking about this as well. So you know, if you look at either a registry that you have or an electronic medical record, you can see there's a pain score of 7 out of 10. So how does this help you? Well, one, it helps you make a clinical decision, because we know for a pain score 7 out of 10, based on the WHO pain ladder, that this was a patient who really must receive an opioid. And in fact, there's case law to say that patients who have a pain score of 7 out of 10 who do not receive an opioid can actually be taken to court and sued for malpractice, and you won't find a lot of experts that will defend this practice of not giving the right medication. So to me, there's a very important clinical decision to be made here based on that pain score. But also importantly, though, we can think about outcomes research that can come from that number as well, right? What are the links between patients who have a pain score 7 out of 10, whose pain score goes down by 50% within the first 24 hours of hospital admission, and that link with hospital readmission, length of stay, total costs, etc. So this is an area that a lot of people are now increasingly starting to see the importance of, is how do you take clinical data and then start to look at outcomes related to that. And then lastly, I'll add in the quality piece. So if you report the pain score at a 7 out of 10, you can now report to a payer that you've done a pain assessment, right? So asking the question met the quality measure. Now you can start looking at whether doing the quality measure or making that assessment in and of itself, even independent of the value you find, may actually link to an outcome, costs, length of stay, readmissions, etc. And so every time we think about doing registry development, or collecting data either from an EMR or from Deduce or wherever we're getting our data, we're thinking about how can that one piece of data be used for these three very important purposes. So we've thought about this in taking the data triple aim and actually putting it into a conceptual model that we call rapid learning quality improvement. Now, quality improvement as a science, as an approach, whether you use the IHI framework or Lean or Six Sigma, is meant to happen very quickly. And in some ways, it can seem at odds with the research infrastructure, because we know in cancer, for example, clinical trials themselves probably take close to about 5 years from beginning to end of data collection, and then there's 2 more years of an analysis period. So we don't find out probably around 7 years after the beginning of a clinical trial in cancer what the actual outcomes are. It may seem quite opposite to quality improvement, where in quality improvement you define a problem, put an intervention in place, cycle it very quickly. Most quality improvement projects do not last years, and they don't even last quarters. Really good quality improvement projects, and I do coaching around quality improvement for different cancer centers across the country. We do cycles in weeks to maybe a month or 2, and you measure real quickly and you look to see, and if it doesn't work, you try something else, and you do continuous cycles of that. And we've thought about rapid learning quality improvement where you're using data coming in from multiple places. I talked about the data triple aim, so maybe coming in through the EMR or standalone registry, you're putting it into your cycle, and you're learning very quickly about what to do, and then either putting that back into a guideline or a new best practice, or you're getting rid of it. And so we've thought about that in terms of integrating into the clinical workflow, doing data collection around quality monitoring, which I'm going to talk to you about how we do that, and then putting that either back into guidelines or reporting that out as research. I'm going to point out really at the end of the day then what people have tried to say are 2 separate things, but actually start to mesh together pretty quickly. So there used to be this concept that medicine should only be, or should focus just on evidence-based medicine. And so this is idea that came out over 20 years ago about knowing what, doing the right thing, and that is context independent, meaning that if the randomized controlled trial shows that all patients should get X, then it doesn't matter whether you're at Duke, UNC, or Sanford, North Carolina, all patients should get X, right? But we know, for example, from Rogers' theory of innovation and others, that the actual time from the development of new evidence to implementation into any place, and Duke may think it's an outlier, but really either it's Sanford or Duke, takes probably around 17 years. And the slow diffusion of innovation is because people very infrequently check on the context. And this is then where quality improvement comes into place, where you're saying, actually, context does matter. There are reasons, in fact, that great innovations coming out from program project grants and R01s and so on from investigators at Duke, as you know, never actually get implemented at Duke, right? Why is that? It's because there's this step here about context that is largely ignored, and this is where actually I see a lot of people that are looking at who are junior investigators are looking at careers of how do we both identify new innovations but then make sure they work locally, where they're looking at the sort of the middle portion of this, where it's evidence-based yet focused also on quality improvement, or another way to think about this would be implementation science. And I think a lot of us who do this type of work have a hard time actually pulling apart implementation science from some of this quality improvement work, and that's okay, because that struggle is real. In some ways, it comes down to whether you're getting an IRB approval or not. Sometimes that's what it is. Other times it's thinking about the type of framework that you may want to use. So we've been working very diligently now over the last almost 4 years on this program called Qdac. Now Qdac was born, Qdac stands for the Quality Data Collection Tool. In and of itself is a tool, but a tool like any others, if nobody uses it, doesn't actually help all that much. Qdac was developed out of this idea that in palliative care, there are roughly 5,000 hospices across the country. They're in every county in the United States, in every single county in the United States except for 2 counties in Montana. There are now over 1,000 different palliative care programs just based on just the statistics of where they are in hospitals. And we know in the outpatient side, they're very quickly growing as well. So there's all these programs. And when we went around and asked them, so how are you doing data collection for clinical purposes? Well, what we find is that even in 2014, only 50% of them use an EMR in any way, be it meaningful use certified or not. And only 50% do. Why is that? Well, hospices, in terms of how they're paid, for example, and stop me if you know this, but hospices are paid a per diem per day. It's the only large payer per diem program that's really known. So if your patient is in hospice, that hospice program, based on the Medicare area that they're in, will receive a certain amount of money per day. So in this area, if you send a patient to hospice, that hospice program will receive about $150 per day to take care of that patient. That includes the oxygen, the medications, the nursing visits, the paying the medical director, etc. And that number is not a number that you can move. Some private payers do pay more than that, but that more could be $175 instead of $150. So hospices have never classically budgeted for paying, for example, for $750 million that Epic charged Duke for, right? Like you couldn't do that. The other thing we know is that a lot of the documentation that happens in hospice, just like in nursing homes, is to meet regulations that can largely go on paper forms and then faxed into wherever. So they haven't had the imperative to move in this direction. Similarly, palliative care programs, which are largely born out of hospices, fall into sort of the same category. They're still struggling with doing electronic documentation. When we started asking them, well, how do you do documentation around quality? Like, how do you know what percentage of your patients had a pain assessment? How do you know what percentage of your patients got management for their breathlessness or their shortness of breath? They said, oh, well, we have an Excel file and we report that. And guess what? Duke Palliative Care has an Excel file as well, which, but I'm not picking on Duke Palliative Care. I think there's a lot of actual service lines at Duke that have little shadow Excel files that are sitting somewhere on a Dropbox folder that when you look back and go, well, how many patients did we see who got blank? You can query an Excel file very quickly. So what we found is that there was no data fidelity in any of those data elements that people were using. Meaning that if you went to the hospice in Raleigh, their registry went name, MRN, race. And under race it said Caucasian, African American, Latino, Asian. Okay, and then the one in Sanford, North Carolina's Excel file went name, MRN, and it said race, and then it said Caucasian, African American, Asian, and under ethnicity it said Latino. Now, the point of the matter is, it doesn't matter how good your data is after that. You could have really great pain scores after that. You can't match patients anymore because one said Latino was a race and one said Latino was an ethnicity. And what we started finding is that these data elements were largely homegrown. People were just making an Excel file, making a form, and using it in their hospice or palliative care unit. And then when we went and looked at it, we said, well, that's not a race and that's not an ethnicity and that's not how the census asks that question, and that's not how clinical trials would ask that question. And we started finding that across the board there was very little agreement. So in 2007, with Duke as sort of the center of this approach, we approached 4 other community organizations who do hospice and palliative care and said, would you want to team up with us and form a collaborative? Now, the reason that we did that is because Duke does not have the ends, meaning the subjects, the number of participants required to build a registry on its own. We don't. Because the point of the matter is we have 1,100 beds. We should be, by any model, be seeing at least 1,100 palliative care patients per year. We see at most 800. Yet, the hospital in Sanford, North Carolina has 125 beds and sees like 250 consults a year. And I've been to hospitals that have 100 beds and see 800 consults a year. In fact, the ends, the patients of interest, are in the community. They're not at Duke, they're not at UNC. So we learned that early on, which means we have to partner to get the ends. But what do we provide as a research organization? Well, we've got statisticians and we've got data analysts and we've got informaticians, et cetera. We have the expertise about how to look at some of the questions that we think are important to look at. So in 2007, we developed what was called the Carolinas Consortium for Palliative Care. And then in that, we've started developing the tools to do standardized data collection within our consortium. So Qdac was born out of this idea, and this is our new logo, thanks to Laura Rowe and others in the room who actually, this is part of the fun of what we do together, is actually sit in rooms and eat Munchkin donuts and talk about what are the color schemes that we want to use, because really, this is the fun part about thinking about innovation, right? Like, startup companies sit in rooms and they do have those same conversations. And we've been saying in our group, why can't we sit in a room and have that much fun and have that kind of conversation too? So we sit and we come up with something like this. We put together the Carolinas Consortium, and as you can see, we have our own logo and we start partnering with others. You see Duke is part of this, but not the major part of it. We've got partners throughout. And what we're able to start doing is build a registry. So I'll cut to the point regarding the registry. Our registry now, for the first version of this, when we started a paper-based form in 2007, now has over 27,000 patient encounters into it. Okay, that's 4 sites, Duke in the center, and Duke hasn't put any patients into, well, has put very few patients into that registry, and we can get 27,000 patient encounters just at the state. And I'll talk to you about how we're actually scaling up from there based on that. So what we did was we built a web-based platform that you can use on a mobile device, a tablet computer, a laptop, a desktop. And what we said is we want standardized data elements that our clinicians will buy into, that map to quality measures on the back end, that can inform our data triple aim, that we can do research analyses, that we can write grants on, that we can do quality improvement projects on. It was actually a big task when we started to do this, which is why there was a lot of planning that went into place. We wanted to, first of all, make sure that data was collected at point of care. When clinicians get really frustrated about what is all this garbage about collecting data on quality, what they're saying is, I can click your PQRS box when I'm done, and when I'm billing, I can do that. But I honestly couldn't tell you if I actually counseled the patient about smoking cessation, right? If there's a box and my salary, for example, is tied to that box, I'm going to be very inclined to click that box. And then you can ask me later about what may have actually happened. We wanted data entered by clinicians to start, because this was really focused on what do clinicians see as being quality of care, how can their data be benchmarked, and how can we start adding, for example, clinical decision support. That is the type of feedback and responses to clinicians that say, well, maybe this is how others may do it instead. We wanted data sent to a central registry because clearly nobody wants to go to prison or be indicted for losing PHI, and so we take that very seriously, which means our servers and all the testing that we do, it meets DHTS requirements or higher, meets HIPAA requirements or higher, and that's been something we've been very careful about. And then we want it optimized for medical devices. What's unique about palliative care and the delivery of hospice care, for example, is most of it does not actually happen in a clinic. A lot of it happens in the hospitals, and a lot of it we're finding out actually happens in patients' homes, in nursing homes, in long-term care centers, and other places as well. So as you know, with the growth of ACOs, including our own, is the growth of the concept of home-based palliative care. You actually put clinical teams together of physicians, advanced practice providers, nurse specialists, and social workers, and you send them to patients' homes. Because the point is that they're not going to show up when things are starting to get bad, and when they show up, they're going to be in crisis, and you want to get them before they hit crisis. Additionally, we know that doing that approach actually saves money for an entire health system, so that's why ACOs have taken a lot of interest in home-based palliative care. So we wanted to make sure that there was a mobile solution for this, because you wanted to walk into a patient's home and do data collection that way, or do it in the office, or do it in the clinic, or do it in the hospital. So how does one build a system like this? Well, you start with a systematic review for quality measures. And what's interesting is in palliative care, even though it's a new discipline, started really as recognized by ABMS in 2007, recognized by Medicare only a few years ago, that there's over 300 quality measures that exist in the field. So how does one start to prioritize what those look like? Well, what we did was we did the systematic review and then went to community clinicians, not to Duke academic clinicians who are concerned about academic things. We went to community clinicians who say, I come at 6 a.m., I leave at 8 p.m. every single day. I do not have an academic day. I do not have a research day. I do not have travel time. This is what I do day in, day out. And we sat them down in a series of focus groups and said, what would be important for us to put into this device for you? And we had a lot of great conversations about what palliative care would look like in the state of North Carolina. So for example, and a classic example is in palliative care, we say all patients should have a spirituality assessment, an assessment of spiritual and existential distress. So how does one do that? Well, if you ask a researcher at Duke, for example, and there's tons of them actually at Duke, I mean, we're very strong in doing spirituality research. There are instruments that start at 12 items and go all the way up to 36 items, meaning you can have a patient fill out a 36-item questionnaire about their spiritual health. And they are very robustly validated in multiple languages for research. But when you go to community clinicians, they say, no way I'm going to do that. So how many questions would you ask? And they say, well, we want to meet the quality measure. And I go, well, you know, in the land of the blind, the one-eyed man is king. And we're kind of the one-eyed king right now, right? Because CMS says, just do a spirituality assessment. So if the payer says, just do one, then we as clinicians get to decide what that looks like. So is that 36 questions? Is it 12 questions? Is it 3 questions? And ultimately, it turns out, from a really great JAMA article written by Karen Steinhauser, who's here at Duke, who validated the question, are you at peace? It's actually a really great question. Are you at peace? There's a 5-point Likert scale to that. Are you at peace is probably one of the best single-item questions for understanding somebody's spiritual well-being and existential distress. Because any answer that says no to that will either then, based on your local system, if the physician feels comfortable going down that rabbit hole, which I generally don't, but if you do, you can go down that rabbit hole. Otherwise, you can say, maybe I can think of a social worker, a chaplain, or somebody else who can help me with this. Because if a patient says to you, I'm not at peace, that is just the top layer of probably a lot of really complex things underneath there that you're going to need time and expertise to run through. So we started going through that, and ultimately then we built a data dictionary, and I apologize, these don't, I guess, project all that well, but these are some screenshots from the current version of Qdac that we're using right now. Imagine that there are about 30 palliative care clinicians across 4 sites across the state of North Carolina who have an iPad in their hand, and when they're talking to patients, they're doing a needs assessment and they're filling this out. So this is the advanced care planning module of Qdac. It has 3 questions, which all came from our clinicians that said you could ask 20, you could ask 5, but really at the end of the day, there's 3 key things we want to know. And these are the 3, preference for CPR, advanced directives, and surrogate healthcare decision makers. We started adding very basic decision support by using color codes. So we actually said, well, if somebody responds with blank, should it send an alert or give you some sort of reminder that maybe this is something you should address next time? For example, a patient does not have an advanced directive in the medical chart. Should there be an alert that goes up? And I will point out, with the money that we've spent and the investment from foundations to put this together, we have features in here that Epic, after $750 million, does not have. So for example, Duke's version of Epic, you can't change the code status in the outpatient side. Believe me, I know, because I do outpatient palliative care, and every single time I have to write it as a diagnosis, and then I have to put it in my note in bold and uppercase so that somebody will see that part. Because if you see the top banner, it'll say patient is full code the last time they were in the hospital, which may have been 2 years ago, and it's not relevant today. We actually have this alert that goes up that shows red, for example, that says patient does not have advanced directive, and that's to catch your attention. Every time you see the patient, that red will show up and say, hey, this is an area that I should be addressing with that patient. Additionally, what we did was we mapped every single one of these questions to a quality measure on the back end. Because remember, making sure that we're asking about quality at the end of the day was our primary focus. So of the 300 or so measures I said that exist, Qdac itself, in a very efficient way, answers 82% of all quality measures that are out there. And every time the NQF or CMS or a payer approaches us or publishes new quality measures, we actually look back and go, yep, we've already got that, because we've been looking ahead by several years. And that's because a lot of us are on several national committees thinking about what they are. And when quality measures are, for example, proposed to NQF there's a good chance that one of us in our team is actually on that committee that's doing that type of submission. So we cover, as I said, 82% of all quality measures that exist. What the clinician is putting in is what's the patient's code status. What we're analyzing on the back end is what percentage of the time are clinicians putting in answering an advanced directive question. So we can start actually benchmarking data of clinicians against each other, of organizations with each other, and with our consortium versus other registries, for example, that we may partner with. At the end of the day, why is this really important? I'll tell you why. The bottom line of a lot of this around benchmarking, clearly there's outcomes research and comparative effectiveness research you can do with such a robust registry. But at the end of the day, if you're a payer, you're CMS, and you say, starting in 2015, if you don't report PQRS, you're going to get a 2% cut in your pay, your Medicare Part B pay. But by 2017, there's a real chance that actually they're going to start looking at the data itself. So you start comparing physicians against each other. Physician Compare is already up, actually. If you go to hhs.physiciancompare.gov, you'll see it actually. You'll see my name, you'll see every other physician in this room, you'll see your name. You will start seeing your HCAHPS or CGCAHPS scores presented there, and you will start seeing things like the percentage of patients that you had, for example, that had timely pain control. As that starts getting publicly reported, it will increasingly be tied to pay, and ultimately then CMS is going to be in this very difficult position where they say, Dr. Kamal, you have, of your patients with a pain score of 7 out of 10, you gave them an opioid 92% of the time, and your colleagues did it 87% of the time, which is right. And we go, well, we don't really know, and then what CMS goes, well, any number under 100%, you're going to cut your pay across the board. So guess what? Everybody loses then. Every clinician loses at that point. So what we've said is actually, if we have a robust registry of 27,000 patient encounters, from a policy perspective, what we can do is proactively go to CMS or Blue Cross or Aetna itself and say, listen, we've got this huge registry, we've got a lot of patients, and we can look at quality measure adherence, whether you're at Duke, you're at UNC, you're at Mayo, you're at Moffitt, you're at NCI, the number is 87%. With this much of a standard deviation each way, here's the 95 confidence interval, this is where the number is. And what CMS, we think, will say, as will others, is thank you for showing us that data, that's where we'd like to put the benchmark. Okay, because they're not in the position of pissing off every physician. They're in the position of making sure the right thing that's feasible to be done is in place, and they're looking for data to help them understand how to do that. Here's another example of a feature we've added, for example, that Epic does not have. And again, I'm comparing to Epic because I think what they imagine when they see screenshots is, why can't this do what something where people have invested hundreds of millions of dollars into doing? And I think our secret sauce and our intellectual property is the idea is that every time we make a change, we think about it as a team, but we go to our clinician partners who are in the community and ask them, does this actually make sense? So when we went to our palliative care clinician partners, they said, you guys do all the research you want, that's fine. And you guys continue to do that with your registry of 27,000 patients. You continue to do that. But what we need to show is program development and growth to our CFO. Okay, so our chief financial officer says, oh, you want to put palliative care into the heart failure clinic at Novant Health, Forsyth Medical Center in Winston-Salem, as an example. You want to do that? How can we show data to help them understand what that is? So the first question is, what does palliative care do when they're involved? And then how do outcomes improve? So we added this before-after feature into Qdac actually to say, what was the state of affairs when you got there? And then what was the state of affairs when you left? Because we know that you might spend 30, 60, or even 90 minutes talking to a patient about their advanced directives because you're helping them fill it out, you're talking them through the document, you're talking them through various scenarios like. So you have heart failure as an example, and the patient brings up a VAD, for example. Point is you're not going to get out of that room very quickly. Okay, there's going to be a lot of discussion that they're going to want to talk to you about. You're going to want to bring in the cardiologist and have this conversation, et cetera. They're going to want to talk to you about, and now that, for example, Medicare has this requirement that patients who have ventricular assist devices have access to palliative care, you're going to start seeing the number of patients getting palliative care consults skyrocket. And I know this from a conference call I was on last night, is that we're still trying to figure out how that's actually going to work logistically, even at a place like Duke. But you're going to start to see a lot more of that, and you're going to need data systems that show that a delta took place. That yes, you were in the room for 90 minutes, but you did this, this, and this. And when you look at an electronic medical record as an example,
other than looking at the orders, it's hard to know what you did. It's like when I document that I had a discussion with a patient about advanced directives. When they came to see me, they didn't have one, and now they do. I challenge you to query that in Epic to figure out that this didn't exist, and now it does, and you can find that in a way very quickly that you can search. Because, for example, the advanced directives in Epic are a photo of a PDF that goes into place, so you actually can't know that. So we added this before-after feature to give us a sense of the delta that occurred during the time. I mentioned some outcomes research that we've been able to do. For example, we looked at patients with cancer and compared them to non-cancer patients, mostly those with advanced neurologic disease, dementia, et cetera. And we looked at their symptom burden that they have. And this is patients who are receiving palliative care. So they give us a sense of their baseline needs, but it also gives us a sense of how we can be doing better. So you can start seeing that actually 50% of our patients have 4 or more moderate to severe symptoms on a 11 symptom inventory that we use very frequently in palliative care. And that's not a small number. You can see fatigue, anorexia, pain, and dyspnea ends up being the sort of common pathway for the human condition. And it's well known actually that whether you're dying of cancer or heart failure or dementia, that you probably across the board will all report pain, potentially shortness of breath, fatigue, and lack of appetite. And those are things that we either fix the certain parts that we can fix, or we help patients and their families understand expectation management around how to approach that, how some of those things may be okay. For example, patients with heart failure, the number 1 and 2 symptom that they have is pain and shortness of breath. And a lot of people don't think, or maybe don't understand, why would heart failure patients have a lot of pain? They do, and across the board they do, which requires that there needs to be really tailored, high-quality pain management that occurs in patients with advanced heart failure, and this is something that we've been able to show from data like this. We've also started doing some work on symptom clusters by looking at performance status, and this is ultimately getting at the idea of how do we solve this workforce issue. We know that 99% of patients with advanced and serious illness spend most of their time not at Duke, right? They spend it at home. And they're surrounded by caregivers who may be informal or informal, right? Daughters, maybe a nurse aide, et cetera, who have no idea how to know when to bring something to the attention of a physician who can maybe impact their pain or their dyspnea, et cetera. So we started building some predictive models to say, well, maybe we use performance status as the common denominator for all to think about. So performance status is how you are able to do your activities of daily living and how you're able to get around. And in palliative care, we use an algorithm that gives you a score that's sort of similar to the Karnofsky performance status scale. Goes 0 to 100. 0 is you're dead, 100 is you're perfectly normal with no disease. 40% means you're bedbound, and so that it goes in increments of 10. So when I say to another palliative care physician, he's about a 70%, they know that he needs help with at least 1, potentially 2 activities of daily living. That may be, let's say, bathing and dressing himself, but otherwise can feed himself, etc. It ends up being certainly in cancer that is highly predictive of your overall prognosis. That if you have a stage 1 breast cancer and your performance status is a 30%, your prognosis is probably somewhere equal to somebody who has a stage 4 breast cancer whose performance status is also around that time. That the human condition is really reflecting, or prognosis is really reflecting, how well you can do the things that you need to do in your just daily life. And so we started thinking about, well, can you start looking at performance status? Could we start training a spouse, an informal caregiver, a home health aide to assess a patient's performance status and say, okay, maybe I'm going to call and let the healthcare team know what that number is. And maybe based on some modeling, we can start thinking about what symptoms that we think they may either have and are underreporting or may be on the cusp of having worsened very significantly. And at that point, you can either have a nurse call them and talk to them about that and say, you know, I'm worried that your pain may be getting worse. Is that something we should address? Or actually send somebody out to their home to think about ameliorating that symptom before it gets worse. And this is one way to sort of visualize clusters. You can see as patients lose their performance status over time, certain things get worse, certain things stay the same, and you can see things like fatigue and anorexia, these 2 common things, actually end up becoming very, very both common, prevalent, that's by the size of the font, and their burden, meaning their average intensity, actually goes up quite a bit as well. We've also, as I mentioned, our collaborative started looking at benchmarks for quality measure adherence. I mentioned that example with CMS. So we've actually started looking then out of, and this is just of cancer patients, for example, where do we start seeing ceiling effects, meaning these are measures that we might think about retiring. CMS, for example, beta blockers and heart failure reached a ceiling effect, which is why Medicare is very interested in retiring elements like that. But in areas like this, we start seeing that, for example, doing a pain assessment is so common that it's maybe not an area that we want to focus a lot on for improvement because we've sort of reached a ceiling effect. But you can start seeing that there's other areas that we've published that show varying amounts of adherence to these very specific quality measures. Additionally, I mentioned some modeling that we're doing. So we started looking at, so I mentioned there's 300 quality measures. We've included 80% of them in Qdac. We have this huge registry. But what we really want to know is, so if you've only got 15 or 30 minutes with the patient and you're a palliative care clinician, that list of 300 and the thing in Qdac, like what do I actually need to do? And so in palliative care, we think a lot about quality of life. And we started actually modeling improvement in quality of life between the first and the second visit of patients with cancer who are receiving palliative care. I'll let you know that anytime people do modeling in quality of life in cancer, the model is dominated completely by somebody's stage and performance status. Because the problem is if you have stage 4 breast cancer, it's hard to have a really great quality of life. And that's what lots of research that's come out of the VA, for example, has said, which is hard to find a predictor that'll improve quality of life that is not trumped in the model by things that just have to do with the disease. So we put a model together taking 20 core quality measures and looking varying rates of adherence to those quality measures and actually map them to those who improved quality of life between visit 1 and visit 2, and we're quite surprised to find that these 3 measures actually came out. So I'm looking at processes of care, but I'm looking at it from a lens of doing it in a quality measure way. So first one is doing an emotional well-being assessment. This is a ASCO quality measure that says that patients have to have their anxiety or depression assessment scored or documented within the first 2 office visits. It's actually used as part of COPE certification. It is not yet a payer-based quality measure, but my sense is it will become. And we actually showed with a decent odds ratio, but not a huge odds ratio by any means, that in this multivariate model that we can actually predict that those patients who had emotional well-being assessment actually had their quality of life, a greater chance of their quality of life improved between first visit and second visit. It's actually really quite remarkable, not in terms of how we approached it, because it's methodologically pretty simple, but that we could even find signal in improving patients' quality of life with advanced disease receiving palliative care, that the same group where people told us over and over again, Arif, listen, just have them have a comfortable death, just don't let them get worse, and you're doing God's work. And we said, I don't think that's good enough, right? We actually have to know what specifically we need to be doing to be doing good for these patients. We showed screening of symptoms during the first visit. That means at least 3 symptoms are screened during the first visit. At least 3, most of them was pain, dyspnea, and constipation. If a screening occurred, it was more likely that management happened in a timely way. It was more likely their quality of life improved over time. And then you can see a trend in those with fatigue management who are receiving chemotherapy. So this is an actively treated population here at the bottom. And so this started to lend credence to those in palliative care who say, well, if I'm consulted to do a family meeting with a patient, I'm not going to do a pain assessment because that's not what I was asked to do by the cardiologist or by the ICU physician. And what we're starting to say is maybe independent of what you were asked to do, this may be considered a core component of your professional encounter with that person because we know there's actually outcomes evidence related to doing those specific tasks. Also going to talk then about how do we use this in a collaborative with clinicians who are not that interested in research. And I think that actually we have to support those clinicians in the community who are providing us the ends for our registry and making sure that we're actually able to move the field forward. So we've taken this rapid cycling quality improvement idea and applied this to now some concepts in behavioral economics and thought about how do we change clinician behavior. We know from the literature that changing clinician behavior is one of the hardest things anybody can ever do because clinicians, for various reasons, are very stuck in the way they do things, and it's hard to make them move. Even if you pay them or take away their pay, it's hard to make them do things differently than what they think is inherently correct. So what we decided was, in early partnerships with Peter Ubel and Dan Ariely at Fuqua, was thinking about behavioral economics applied to this, is how can we use data and giving data back to clinicians to actually making them change their behavior on their own. without us actually doing a lot more than that. Because what we don't want to do is chase down physicians and say, you're not doing this as well. What we want to do is let them come to that conclusion on their own. So we put this project together where we had 3 cycles, and this is a very sort of behavioral economics type of approach, short cycles, small experiments with pilot projects in it. So what we thought we'd do is focus on timely management of pain, constipation, and dyspnea, which is shortness of breath. And what we said was, what we'll do is we'll first let them just do it in Qdac on their own. Then we'll start giving them reports that just say, Dr. Kamal, this is how you're doing. And then what we'll do is in the 3rd cycle is we'll give reports versus other clinicians in the collaborative, so a comparative report. This idea that if you see how others are doing, maybe you'll change your own practice. This is an example of a report that we started putting forward. I show this example because it's nothing complex. It's nothing that required, there's a lot of great hard work done on the back end to make sure this report is automated and go out. But as you can see, all we were really trying to say is, this is how you do, this is how you've done to date, and this is how your partner's doing. All we're doing in the background is just watching very passively to see, does that change anything? Now, I will say up front before I show you the results that any limitation in doing quality improvement research like this is the Hawthorne effect. The Hawthorne effect is this idea that if you're being watched, you're going to do things in a way that is better than if you weren't being watched, right? And Hawthorne effect actually in quality improvement works really well, and we often use it to our advantage. And the question you always have to ask yourself is it the Hawthorne effect alone, or as the Hawthorne effect wears off, which means after we stop telling people that we're watching them, do they still have a similar level of performance, or does that drop off over time? So what we were able to show in a very small, this has tons of limitations, okay, in a very small period of time, is that we can hit a ceiling effect. We can get clinicians to buy in to doing timely management of pain, dyspnea, and constipation, almost to a point where they absolutely do hit a ceiling effect, and actually comparative reports actually reinforces that effect. And right now what we're doing is looking at our data as we stopped this quality improvement project to see where do these numbers go. I presume they will go down from 100%, but we will hope to keep them above a number like 75% in our consortium, because they know that is an important area we've decided as a collaborative to follow over time. I showed you what we're doing now with tablet-based technology and using Qdac. Clearly the idea is the integrated data element that goes across time. So you imagine you could take a mobile health, like an iPhone app, you could talk to a PRO, which would be a patient-reported outcome, doing a tablet with a patient, who's the patient filling it out in a waiting room, that then talks to Qdac with as a clinician, filling it out from their end, and then ultimately we move that up to the population health level as well. Keep in mind that all the basic tenets of what I talked about, interoperability of data elements, the fidelity of them, using the data triple aim, thinking about data that can be used in 3 different ways, can move up that ladder in either direction, so that a PRO can move up to the clinician-centered side, can move up to population management, and back downwards to mobile health. As long as you're thinking about that pain score of 7 out of 10, and you're thinking about how each person will answer it, and how you do the analysis on the back end, and how, for example, a quality measure attributed to a physician may actually be informed by a patient filling out something on an iPhone at home, makes this actually very innovative, because very few people have actually thought about how that might actually be done, and this is something we're focused on. This is Qdac.org, which sort of summarizes a lot of what I've talked about. This is our new website that we just released a couple weeks ago, and this reflects a lot of hard work by people in this room that helped design this. And we talk about a rapid learning quality improvement approach. And I know it's hard to see, but I mentioned if we can take 4 sites and Duke in the middle with foundation dollars, and we can get 27,000 patient encounters in a registry that is just recently now electronic, previously was paper-based since 2007, and then we have people knocking on our doors to join our collaborative, then we probably at some point need to let them in. So actually we now designed what's called the Global Palliative Care Quality Alliance. It's headquartered at DCRI. It's the only thing like it in the world that is using a federated set of data elements that now has Australia coming on board, and we've got 12 sites across the country that include the Mayo Clinic, the National Cancer Institute, Moffitt Hospital, and a list of like 15 others that we are keeping at bay because we want to make sure we manage growth well. If we were not managing growth well, we would probably be up to 30 right now and struggling a little bit around the infrastructure to support that much. We know our servers can hold that much load. We know we've got a lot of partners. And actually, we've got partners at like Tampa General Hospital. The reason they're using Qdac is because to be advanced certified for palliative care in the United States by JCO, you have to demonstrate continuous data collection around QI, evidence-based practice, and having a quality improvement program that's based on data that you're collecting in terms of a registry. Guess what? All three of those things are met by Qdac, and that's why they're using it. We've got a lot of other sites, including Medicaid providers as well, and integrated health systems like Geisinger and others that are very interested in using Qdac, largely because we are not asking for a whole lot in return other than access to the data, which we're using for our purposes, but they want to use that for advanced certification for palliative care. There's only 20 sites in the country, and eventually it'll become, we think, a mandatory thing. Actually, Duke's moving forward with that as well. That doesn't show up very well, but those are the 33 or so sites that are in the Palliative Care Research Cooperative Group, which is the only national clinical trials collaboration around palliative care. It's funded by a U24 grant from the NINR for $10.5 million, headquartered also out of the Center for Learning Healthcare here at Duke. We are co-PI'd with the group out of UC Denver. And what we are planning on doing is taking Qdac and putting it in every one of these sites across PCRC. That's Mount Sinai, that's Harvard, that's Northwestern. That's sort of all the big name folks that are in the field, that they will quickly over the next 2 years actually start using our infrastructure to do their data collection as well. And we have an R18 grant. That's the aims from the grant themselves, which we're about to kick off actually on November 1st. We'll have 5 sites across the country implement a Qdac, a PCRC version of Qdac, which they'll get. And they'll do that through May. We'll do a feasibility study. Then we're going to start defining national benchmarks for the discipline using data from 33 sites across the PCRC. And then we're actually going to start developing decision support within our collaborative to start saying, well, what do you do with a pain score that's 7 out of 10 even after giving an opioid? When does one move to methadone or ketamine or other things? That's going to be a lot of the intellectual property that comes out of this work. Qdac will then be the delivery mechanism for that moving forward. Here's just an example of what we'll be talking about at our investigators meeting actually tomorrow in Chicago about the kickoff itself across the 5 sites and then the ultimate implementation across the board. And then lastly, I'm going to talk to you about how we've been doing some of this with registries we have within Duke themselves. So many of you know the Choosing Wisely initiative that's put forward by the American Board of Internal Medicine Foundation. We've been looking carefully at our own data as well to understand how we may be adhering to those measures, partially because if you look around the country, nobody actually publishes any of this data. So for any of you who think that this stuff is not publishable, in fact, every one of these pieces I've talked to you about is a discrete publishable piece. So across the country, we know that doing advanced imaging in early stage breast cancer, that's 2A or less, that is less than 4 lymph nodes in the axillary space, should not have a PET, CT, or MRI brain. And that's a quality measure put forward by ASCO and largely accepted by payers as well. Should not have an advanced image. So we looked at Duke's data. Why? There's 2 reasons you could look at Duke's data. One, you could be you could sit there and not report it to outside folks and say we'll use it only for quality improvement, or you can do how we approached it, which is to be the first to publish, the first in the space, and say we think this is where the benchmark is. Because notice in Choosing Wisely, the benchmark is not 100%. The benchmark is largely left to interpretation. So we were, I think in some ways, quite savvy. We looked at our data and said it's about 20%. And when everybody got upset and they said, Arif, you can't go to ASCO and say Duke's doing something wrong 20% of the time. And I said, actually, that's not the message. The message is going to say, with a very high tertiary care population and patients who have very complex disease, 20% is what we think should happen, and that's the benchmark we're going to put forward. And then our colleagues at University of Michigan and others said to us and said, wow, that's pretty brave. Actually, we're going to report that as the benchmark for the discipline. So suddenly, our oral presentation at ASCO became the benchmark for the discipline because we were sort of bold enough to put that forward. The other thing that we looked at was it can't be all bad. So we looked at why people were getting advanced imaging. And we actually took 100 charts and looked at them manually. And I had an oncology fellow look at it. I had an administrative director, an MBA, look at those same charts. And when they disagreed about whether an image was quote unquote appropriate, it came to me to adjudication. And what we found was that at least a third of those, actually close to about half of those, had a discrepancy between the two. And most of those were because of nuances between typical and atypical findings in early stage breast cancer. So this is a patient with early stage breast cancer who syncopizes, falls, and goes to the ER and gets a CT head. Was that appropriate or inappropriate? Well, based on an administrative data set, it would say that was inappropriate because you got it within 30 days of diagnosis. When a clinician looks at it, you go, patients with early stage breast cancer, even if they have brain mets, they don't syncopize because they don't. You don't pass out because of brain mets. So that had nothing to do with the two things. It actually required us pulling this out. So what we started saying is of those 20%, we think a good percentage of them are actually very good reason, clinical reasons why those images were actually obtained, and we can actually show that data by looking through. And here's that example of a syncope. A patient with a history of a chronic myelogenous leukemia who's an esophageal mass who has a history of breast cancer. What do you do? Should you image or not? Absolutely you should. And these are just some of the things we were able to show. I'm going to wrap up by talking about another R25 grant we have. This is partnering with ASCO, the American Society of Clinical Oncology, 35,000 oncologists across the country. This is the AHA-ACC for Oncology, ASCO. We have a grant with them. This is the first time they've ever partnered with an academic institution as co-PIs, an ARC grant to develop an online learning collaborative around quality improvement. We have 25 sites with money from ARC and the California Healthcare Foundation to teach them quality improvement for palliative care in a virtual way. And this infrastructure is sitting on our servers shared with ASCO, and we're actually seen as the leaders in this space moving this forward. I did not get a chance because of our time to talk about where we're actually applying Qdac to multiple other places. Every one of these is grant funded. So I told you the Palliative Care Quality Alliance, the PCRC, we're doing a home-based palliative care and home-based primary care version of Qdac that's going to go forward. That comes from the California Healthcare Foundation, the Commonwealth Fund, which is headed by David Blumenthal, who understands how important IT research is. We have a pilot grant to do with our gynecologists, oncologists. We're working with ASCO on using this data to understand what primary palliative care looks like, and I mentioned our virtual learning collaborative. And then lastly, I'm just going to talk about this idea of QCDRs. We're thinking about making a registry for all of palliative care that would be housed at Duke, that would hold data that would then be submitted to CMS for reimbursement, and this is something that's ongoing in the works. And lastly, what I think is really fun for us is we're starting to branch out and think about other things that we can do. So MyQ is an idea formed from this group, largely in terms of thinking about how can we give tools to patients in their hands to be better prepared to talk to an oncologist. And then we went, actually with Chris Cox's recommendation, to the computer science folks on the undergrad campus and said, do you have some programmers that we could pitch an idea to? And they gave us 3 really bright kids who are helping us build a mobile app that uses crowdsourcing to help patients and caregivers know by looking at their phone what types of questions they should be asking their oncologist, both before they come to the visit and while they're in their visit themselves. And it doesn't give the answers, it gives you a set of questions, because that's, as clinicians, you're spending a lot of time trying to get patients to ask you the right questions or think about what's on their mind. And we are using a crowdsourcing validation algorithm on the back end, not much different than, let's say, Pandora, to actually rank questions that the users of the app are using so they can start seeing what are high yield and highly valuable questions they should be using when they come and talk to their oncologist. So this is a really fun project that we're working on as well, and clearly has several research aims. I'm going to end with this slide, which is really this idea that there's a lot of work we do within the Center for Learning Healthcare and thinking about rapid learning designs across all aspects of where one could do research. Clearly there is the basic science and translational end, and we've been doing some work with clinical trials for early drug development, for example, in management of fatigue and anorexia. That falls on the left side, but we're starting to do now a lot on this right side, and you can see healthcare quality is just as important part of a building block of all the things that we do. Policy, CER, patient-centered outcomes, and personalized research is all sort of part of that. And so with that, I'll leave you my email and then answer any questions. Thank you.
Great, thanks for a fabulous presentation. Any questions?
Who's going to do it? I'll take it. You sure? One last chance? Okay, so first off, thank you for a phenomenal research conference. Certainly, whatever Amy's bug was, has affected an entire organization. You guys have more energy than very remarkably impressive. And also remarkably impressive that you're trying to take on an area of medicine that, to date is thought to be much more qualitative, and yet you've tried to make it remarkably quantitative. But I'll challenge you a little bit on that. It's a challenge to know when is the data real, when are any of the signals you're seeing real, and how much are you perverting the system? And let me just sort of go through those 3 thoughts. So the first is the idea that the pain one. How accurate is that data? If most of us would say that data is filled in by people who generally don't really think about that measure being used for anything other than they have to do it as part of their job. As a result of that, you're tying it to decision making and in part a failure on somebody else's part if it's put in wrong. You can show correlations between centers that do better at this and outcome. Is that a correlation between people who generally document better, generally do better care regardless of the metric you take? We've correlated completeness of notes in charts as correlating with better quality care and actual mortality in MI care. Is it the process itself, or is it just a reflection and association that you see? And then finally, do you make the system worse in two ways? Worse in the idea that once you tie it to incentives and public reporting or rewards, I guarantee you'll get 99%, but will the patient have ever benefited from that? We made smoking cessation a title for you have to give smoking cessation counseling to patients with MI. We are now hitting 100% because we put stop smoking on your discharge forms, and no one gets any more likely to quit smoking than before. The final part of this is, do you make the system even worse, not just no impact, in that now, instead of providing that time that you could have with the patient where you're actually providing some degree of palliative support, individualized, you're documenting on a machine. So those are just the challenges for the day.
Yeah, I mean, I agree. Those are all really great points. And I think what we've tried to do is be agnostic as to the answer to those questions, right? We've gone to clinicians and said, what's the right way to document this where you're not just checking a box, like what's meaningful? And so, so we've wrestled between saying, well, do we just put down a pain score, or do we put down something more than that? And I think the feedback that we've gotten from clinicians is that when they're doing documentation in their EMR, they're focused on very sort of, okay, let me just make sure I tell the people what I need to tell them. When they're interacting with Qdac, which is a separate system, they know that we're doing this for quality improvement. I guess there's a certain group of people who may be saying I'm going to game it both ways, but we try to be non-punitive. Nothing's attached from our end to reimbursement, certainly. We don't report individual people's data. We report organization level and that kind of thing. And so we're hopeful that maybe people will be a little bit.
But if you have success, you will. Because this model, if you really want to take it forward, you would love for it to be adopted by the world, because then the world would have to adopt it.
Yep.
You'd have a very successful product, you'd be able to measure the entire world, but it's only because it's linked to a performance measure, which now perverts the system.
Right, and that, you're right. I mean, that's the challenge.
Yeah.
That's the challenge.
Wonderful work. The question I'll ask is relates to your multiple comments about Epic. So Epic was one good that came out of it. It was all the piecemeal systems that we had to click to that didn't talk to each other. So it was obviated by now having an English and HR across. Does Qdac sit on top of Epic? Does it get in and the information go both ways, or is it just unidirectional as a separate standalone?
Yeah, so we have at least one pilot project that's looking at taking data and out of here and putting it into Epic itself as a report. The challenge is the bidirectional data flow issue, as you know, right? Is that, for example, if Qdac gives a decision support recommendation, for that to go into Epic and come in is almost impossible. And we've talked to them and they're not really sort of willing to work on that right now. And so largely we've said that the uniqueness of this is that we can start doing decision support that is helpful to the provider. What's the value add to the provider that's using it? We've worked with some other cloud-based EMRs where we have before pulled demographic data out of that EMR and it populated a lot of Qdac, then you fill out a report and something went back in. What's interesting though is that no EMR vendor wants to pay for that. For any of this. So they've come to us and said, well, if you're willing to give us your IP and then you're going to write a foundation grant for us to put it in, sure, we're happy to do that. I mean, I've sat in some really high-level meetings with Epic on the ASCO side where their pitch was, give us your IP and we'll allow it to be used. And we said, hold on, we've spent grant money in 4 years and a lot of hard work developing what those elements even are. We're not going to give this to you. So right now we're actually thinking about some payers. There's one in the Northwest who may be willing to front some money for us to put that into an EMR system. But it ends up being this challenge. Nobody wants to put the money up for that.
Thanks for a very thoughtful and impressive presentation.